Okay, so today is Lyme disease. There's an urgent need for better testing. I'm Dr. Martin.
Chronic Lyme.
In chronic Lyme disease.
Yeah.
Yes, sorry. In chronic Lyme disease.
Yeah.
Sorry.
Yeah.
So in chronic Lyme disease, there is an urgent need for better testing. I'm Dr. Martin Rutherford, certified functional medicine practitioner and chiropractor.
Dr. Randall Gates, board certified chiropractic neurologist, also a chiropractor.
And brief discussion, there's an urgent need for better testing today in the chronic condition and chronic pain world. We're going to do a whole talk on this. We just had a brief discussion on it beforehand because I thought it might put our comments on Lyme disease in better perspective today. I've been in practice since 1980. I started out in nutrition and diet, even though I was also doing chiropractic, but I went to a school that was very, very, very comprehensive in its teachings, and diet and blood sugar diets and supplements and so on and so forth. And I did that for about 5 years, and the testing was pretty tenuous at that point in time. We're doing a lot of muscle testing, which has its validity in certain areas. In other areas, my personal opinion is it doesn't. And then there was just a lot of things that people were doing that were, I thought, difficult to really pin your success on. Oh yes, you have a thyroid problem, or oh yes, we put a electrical device here and you have a thyroid problem, things of that nature. I don't mean to be denigrating. I'm just saying I've done these things. And there's been this huge vacuum in the field of testing for chronic pain. Just look at the medical field. The medical field doesn't know what to do with it. Everybody comes in here, we deal, for those of you who don't know what we do, Dr. Gates, functional neurologist, I'm a functional medicine doctor. We bunch these two professions together. We treat chronic pain, fibromyalgia, peripheral neuropathy, chronic fatigue, dizziness, vertigo, Lyme, bacteria. We treat migraines, we treat concussions, we treat a ton of things, okay? And we're moving largely towards a neurological base. But the bottom line is that the testing isn't there. And I have a patient that I'm talking to today, and I have a file this thick of testing, and so much of the testing is incorrect. It's bad. It's bad. The testing doesn't even make any sense. If you understand biochemistry, if you understand testing, you could just look at it and go, here's what the literature says, here's what the testing's testing for. It's not even the same thing. It doesn't make any sense. But the doctors are using this test as the gold standard. And so these people are getting treated by the gold standard alternative test. The medical doctors don't know what to do for Lyme, or they don't know what to do for fibromyalgia or chronic fatigue or stuff relative to testing. They don't even know what to do for thyroid, frankly, at this point, relative to testing. But everybody's getting treated by the test, and now half the country has chronic conditions and autoimmune problems. So I just wanted to throw that background in. We're going to go into this a little farther, but I don't want to lose your attention, because we're going to apply that to Lyme. So we just want you to know, especially the Lyme patients. I know I do the initial consults when people come in, and Lyme patients they're a different breed, because they're sick. They're not getting any results. Some have got results from going to certain different areas, but the testing, it's almost like there's the lexicon of Lyme, there's a testing of Lyme, there's the bands, and there's the Borrelia, and there's the Burgdorferi, and it's kind of like, it's hard to say, but when the person comes in and starts educating me on it, which is fine, but they're educating me as the expert, and what we're going to tell you is a lot of these concepts that seem to be, cement, are being unraveled with the research, and we've seen that. Dr. Gates has seen that. Dr. Gates has done a tremendous amount of research that I'm referring to. We're applying that here. We're seeing good results in a lot less time, a lot more cost effective. That wasn't a sales pitch. I'm just telling you, we're seeing it. So we're sharing this with you. So that's kind of the background of where this is going to come from. The Lyme testing is for the chronic pain patient, for the chronic Lyme patient, needs to be rethought. It needs to be heavily rethought, because it is leading doctors to do treatment that in most cases is not going to get the person where they need to get. So Lyme testing, it needs to be rethought.
It does, because
urgently.
Yes, urgently. Basically, we have a model, and a lot of you know all the background on this, and please, lose your lingo for this talk. We're not always trying to strictly abide by your lingo, because frankly, it's kind of a lingo separate to the Lyme literate world or the ILADS world. We get all sides of it, but don't jump down our throat for that. Just going to open up with that discussion. Secondly, is chronic Lyme an issue? I feel wholeheartedly that it is. We see a lot of patients who have chronic Lyme or post-treatment Lyme disease syndrome, or whatever it's called. We see a lot of these individuals who come in and they're very sick. As many of you know, the CDC came out and said a lot more people had Lyme disease than they ever thought. Upwards of 2009, even in Canada, a lot of Lyme disease was not even acknowledged. I just read an article this morning from the Canadian Medical Association journals, kind of like our American Medical Association journal, where they're talking about how even a lot of doctors in Canada aren't even familiar with Lyme disease, which is a problem, which is not a surprise to many of you, but it is a surprise to me, just thinking like, how do they not know about Lyme disease? And so Lyme disease has seemed to spread relatively rapidly. All these questions about, so we just described this condition in 1975, in Lyme County, Connecticut. I think it was Dr. Steer, wasn't it? Many of you will know that. Some people say it was in existence before that, even described in the 1800s, I believe, in Europe. But a lot of people think that maybe it just appeared in 1975. So there are all these questions surrounding Lyme disease. And then we have the classic infectious disease perspective, which is, it's an acute illness. There may or may not be this chronic form, but taking antibiotics for it, there's no research for it. So we attach articles to today's broadcast. You can find them on powerhealthtalk.com. But in these research articles, I attached them just so you can see that they still think that chronic Lyme, there's no treatment for it, if it even exists.
Right.
And so that's the prevailing notion out there. And so I would say, rather than everybody in the Lyme literate world kind of having this, and I can understand why you're disenchanted. I really can. I'm not trying to be unsympathetic to that. But if we have a real condition that seems to be spreading, Lyme disease is more common and chronic Lyme seems to be extremely common, why don't we look at reclassifying how we're testing for this, so we can actually say, okay, there's definitive evidence that this person has it. And many of you are familiar with the most common testing modalities used in the Lyme literate and ILADS world. These are antibody tests. And so we create our own criteria then. So we have this criteria for this test saying if you have 2 bands, based on certain bands, but if you have 2 of them, you're positive for Lyme disease, whereas the CDC says you need 5, which we get because a lot of you go back to Dearborn, Michigan, when Lyme disease was first evaluated in the testing for the vaccination. And so the CDC's perspective is flawed based on that. It's neither here nor there, because really the point is we're talking about chronic Lyme for most of you. And chronic Lyme is still being diagnosed based on antibody testing. We're talking antibodies, immune cells.
Maybe explain what an antibody.
Okay. Antibodies are immune cells. Think of them as immune missiles to the Lyme bacteria, the Borrelia species. Well, we just talked about last week how Lyme disease came out of UC Davis, Lyme disease, and we thank the viewer, so to speak, who kind of created this dialogue. Mm-hmm. But it came out of UC Davis that Lyme disease, the Borrelia species, interfere dramatically with how our lymph nodes create an attack on the bacteria, so we don't create long-lasting antibodies, immune missiles, think of them that way, to this bacteria, and our immune system is completely disturbed by it. So if you're not making antibodies to this bacteria long-term, why the heck are we still checking for antibodies in patients who have chronic Lyme disease? That's really the question, and that's the point that you all really need to consider. Because if we have a legitimate illness out there, then you need, I was thinking about it this morning. I don't know what the exact solution is. Maybe you need to write your congressperson. Maybe you need to go talk to local research doctors at the hospital or the universities that you're surrounding. This discussion needs to come up because more and more people are being diagnosed with Lyme disease, and this chronic Lyme epidemic is burgeoning on the horizon. And the first thing is we have to be able to test for it, because we know that a lot of you are sick. Now, we've talked about another broadcast that there seem to be these autoimmune responses that are now evident in certain portions of Lyme disease. Yes, it applies to the Lyme arthritis, but go back and watch our broadcast last week, because when you have an autoimmune issue, these immune chemical messengers go into the brain, can interfere with brain function, and possibly that's what a lot of you are experiencing as neuroborreliosis or chronic neuroborreliosis. And the problem is, again, how is it standardly tested for in medicine? They do antibody tests based on your cerebrospinal fluid, your CSF. Well, again, we're talking about an antibody test for a bacteria that interferes with the immune system's ability to make antibodies to it severely. So I hope that you get the point that we just need a different testing paradigm for this issue. And maybe you need to talk to your Lyme literate doctors. Again, you need to talk to research facilities about this issue, because we need a solution for this. What do you want to interject?
Well, this was your topic in a sense of, so you had an idea. I mean, to me, I'm not sure to add anything. I mean, to me, we don't want to go to the point of it's an autoimmune problem. We've done presentations on this, and there appears to be, even if you embrace that paradigm, which we do, because how we got here was treating fibromyalgia patients who came in for fibromyalgia. We put them through our paradigm. We were not treating for bacteria. We were not treating for Lyme disease, and they were getting better. In our paradigm, the only thing it could have been was autoimmunity. But even autoimmunity testing
is not perfect.
Is not
right.
Very good.
Right.
So I wanted to thought maybe to add that to the dilemma. So let's say you're willing to buy our paradigm, and to add one other thing to the aspect of the Lyme potentially causing neuroborreliosis in the mind. You rarely get one autoimmune problem. So one of the confusions in the Lyme patient is they get an immune attack on their joints 30% of the time or 15% of the time, whatever it is, according to them. But most of the time, if you have rheumatoid arthritis in your joints, you're going to have other autoimmune problems. Maybe you're going to have psoriasis. Maybe you're going to have an immune attack on your thyroid. Maybe you're going to have an immune attack on your cerebellum. So now you get this attack on your joint. Now you get all the symptoms of Hashimoto's. You get tired, you get fatigued, you start putting on weight. Now maybe your gut starts getting bad. Maybe you start getting, eczema, or psoriasis, or maybe you start getting dizziness, vertigo, and bounce. And next thing you know, you're off to the Lyme doctor, and it's like everything's Lyme. So I just thought maybe to throw that in there to even expand beyond the Alyssa Western blot hygienics flow is probably not the way to go. I think even they admit that. Even the people who do these tests admit they're not like the most accurate tests. But then you have that confusion of if you can break away from the lexicon of Lyme and the neuro and the borreliosis and all those things, and embrace that it's more likely an autoimmune problem and the immune system needs to be damned. And the testing there is poor also. It's poor.
And yeah, and then you bring up with these antibody tests. So now we have these antibody tests in the ILATS world, the Lyme literate world, where they have huge degrees of false positives. And I get their sensitivity argument. So there's the whole argument, okay, let's use HIV as an example. You take a bunch of people who think they have HIV. You want to run a test where you don't miss anybody who has HIV, right, on the first test. So that may mean that you have some false positives, but in the research world, that's okay, because we don't want people out there thinking they don't have HIV who have HIV, as an example. So then you create a second test to confirm, okay, well, we have some false positives here, but let's use another test that whittle out those false positives at that point. That's kind of the argument with some of these Lyme literate tests. I'm trying not to use just one name, because there are other testing facilities too. But then you have a bunch of false positives, and the argument is that, well, maybe you have Epstein-Barr virus. is the cause of this. Maybe on your urinary culture for the PCR test, you have a urinary tract infection. These are all the arguments coming up against those of you with chronic Lyme who are suffering, who are sick. And I think rather than just saying, well, we have a different model, I think we need to all say, okay, the testing for chronic Lyme needs to change, because there is evidence there's fantastic evidence of what this bacteria is doing to subvert the immune system, actually almost to kind of destroy the immune system. And there have to be ways to test for this. Now, I'm not a research scientist that does molecular biology, microbiology testing, but there are people out there that do that. And so I just think we all need to start brainstorming, from the clinicians on our side to the Lyme literate medical doctors, to everybody out there, on how to address this problem. So we're not coming at you with a solution, but we're just saying, this is the problem that I think a lot of you need to start focusing on, rather than maybe, you know, the alternative theory, so to speak, as to what's going on and why this is so rampant. And because this is actually going to work towards a solution, greater acceptance for people 20 years from now who are diagnosed with chronic Lyme. We need this to be accepted so that we can actually have a treatment modality for it.
So yeah. So your dilemma is the researchers maybe don't, who are doing the research to do the testing, maybe don't think there's Lyme. You get to the GP who thinks there's Lyme, but only acute. You get to the,
well, actually, some of the GPs now are much more open to it, to chronic Lyme.
But then you get into the person who believes the chronic Lyme, whether it's the GP or whether it's the alternative functional medicine practitioner or whether it's the ILADS guys, and they're using testing that is pretty much in the literature considered to be inconsistent and unreliable. And then you got us saying that it's an autoimmune problem. And if it's an autoimmune problem, which we believe it is, because that's the way we approach it, and we can approach it assuming it's an autoimmune problem, apply that and get some decent results, because have to do it that way because the autoimmune testing is unreliable. It's inconsistent and it's unreliable. And again, that's the literature saying that. That's your dilemma. That's Dr. Gates's point.
Mm-hmm. Exactly. So that's why we need to come up with a test for Lyme disease that's not based on an antibody to it, basically. In my opinion, maybe there is an antibody to it that we just haven't found yet. But the current concept of antibody testing for Lyme disease, when you don't make antibodies to it in the chronic phase, doesn't make sense. So, all right, that's this week. We'll talk about Lyme next week. We're probably going to go into more functional medicine testing for Lyme disease. Functional medicine in the Lyme literate world, the ILADS world, has gained a lot of notoriety. We'll talk about this not only as it pertains to Lyme disease, but also other chronic pain conditions and some pitfalls there as well. All right, we hope you find this as helpful. Again, these last 3 weeks, we're talking about Lyme-related topics. We're hoping for more discourse. If any of you have information, or any of you big Lyme literate doctors in that world want to discourse with us, we'd be happy to. We'd be happy to, because there just needs to be more discussion rather than, we just need more discussion. So we'll see you next week.